Well, hello and welcome again to the Medical Mastery Podcast, the podcast of the Emerald Coast Medical Association. I'm your amaranthine host, Don Davis, MD, and I am excited to have a guest, a pathologist, Scott Taylor, MD with KWB Pathology. Thank you for being here today on Medical Mastery.
I appreciate the invite. I'm very excited to be here.
Okay, well, we're going to test that grounds here in just a little bit, okay? So according to my notes here, it says you're a pathologist. I have no idea what that is.
A lot of people don't know what it is.
Well, okay.
My family probably doesn't even know what that is for the most part.
I'm not entirely certain my family knows what I do. So I've had this dream for some time that I want my wife to find out that I had never actually graduated medical school. I'm just going every day to the mall for hours.
Hanging out, doing some
yeah,
laps,
exactly.
doing the walking around.
Just figuring it out. Okay, so Chris, you edit that out, please. All right, so now let's start off. We're going to get to your story. We're going to get to what you do day to day, and probably answer some burning questions that a lot of our audience will have about what it is that pathologists do, and hopefully you can help us solve medicine while we're here.
Okay.
But let's start off by talking about you. Where are you from?
I'm from right here in Panama City.
Oh, I've heard of it.
Yep.
Okay, good, good.
I grew up over in Callaway, behind Brooks Bait and Tackle, an old block home.
All right.
Until about I was age 8 or 9, and then we moved out to the Deer Point Lake area. Went to high school at Mosley.
Mosley, okay,
Yeah.
Mosley Dolphin, yeah. My wife was too, yes.
Graduated in 05.
Okay.
Met my wife in high school. First time I saw her was at Harders Park. We were on opposite soccer teams. First time I ever laid eyes on her. And our first date was a walk down Panama City Beach, you know.
Right.
So a lot of history here.
Yeah, true local, huh? Okay.
Absolutely, 100%. My first real job was at one of the local hospitals here. I was valet parking cars.
Oh, fancy.
Filing x-rays.
Filing x-rays, the old school, yes.
Films with the huge folders, you know, yes.
Yes, my wife's practice used to have the rolling light boxes there. That was, again, halcyon days.
Very archaic.
Yes, indeed.
How far we have come since those days.
In some ways. So you born and raised here. Now tell me what your family does.
So my mom's an RN, 35 years. She just retired.
Good on her.
About 6-8 months ago.
Shout out.
Very excited about that.
Yeah.
My dad cut grass for a living.
Okay.
Did that, owned his own business, did that for a good number of years.
All right, great.
So yeah, I think that initial interest in medicine for me probably came from my mother, you know, watching her every day, go and take care of patients. She worked on the cardiac floor here in town.
Okay, I'm sorry.
And so she kind of instilled a little bit of that.
And then also apparently, you know, some hard work values that your dad is instilling in you.
Absolutely. Taught me how to work hard. One of the things he always said is you might not be the smartest guy in the room, but you can outwork everybody else. That's something that you can do. That's something that you can control. And so that kind of stuck with me.
You know, the unwillingness to stay down if you're knocked down, that is what truly is going to create success, because, you know, as you've gone through this training that we've recapitulated a fair amount of that, you get knocked down several times. I'm going to get back up. I'm not going to stay down.
Absolutely. That's one thing I've kind of learned throughout my careers. There's going to be a lot of hardships, trials. People are going to tell you, no, you can't do something.
Of course.
And I think that's what gets you through it, is you just never take no as an answer. Keep
too
going.
stubborn to take
That's
that.
right.
Yeah. As soon as you tell me no, I'm like, all right, no, I don't know. Now tell me about where'd you do undergrad?
So I got my associates here at Gulf Coast.
Okay, super local guy. Okay, great.
Yeah, saving money, staying at home, doing
at you.
all that smart stuff, right?
Yes.
Right. And that's also about the time I met my wife. So I'm glad I've made that decision.
It's a smart move.
Yep, absolutely. And then I did my undergrad over at FSU. Got my bachelor's degree there.
Okay.
Yep.
What'd you study at the time?
Biological science.
Okay. Now, so were you leaning towards medicine at that point, or did biological science hold some sort of thrill for you?
No, I was kind of leaning towards medicine, you know, at that point. There were other things kind of in that field that just kind of interested me. At one point in time, I did kind of look up what I could do with my bachelor's degree there, and it's not a lot.
It's not much.
Counting sea turtles was on the list for not very much and per hour, and I said, well, I better get this medical school thing right.
Let's see what the next level is.
Right.
Yeah,
exactly. Yeah. So I got my bachelor's degree from FSU. I had a little bit of off time between then and applying for medical school. Worked on my master's at Berry University down in South Florida.
Gotcha.
Did that for 6 months. And then obviously applied to medical school, got into medical school at Lincoln Memorial University, DeBuss College of Osteopathic Medicine.
Okay, yes.
It's located in Harrogate, Tennessee. Most people don't know where that's at. It's up in the Cumberland Gap area, about an hour north of Knoxville. Real small town.
Yeah. Smoky Mountains.
Yes.
Beautiful foliage.
Absolutely gorgeous.
Yeah, it is.
Gorgeous scenery. Good people, hardworking people. It was a new medical school at the time. It was a huge blessing for that area, just bringing in clinicians and some medical knowledge into that region that was truly underserved.
Yeah.
And so, that was a really good experience for me. I enjoyed my time there greatly.
So what did you think about medical training going through it?
It's the hardest thing I've ever done.
Yeah.
100%. It's a full.
You didn't know how hard it was going to be.
No, I didn't. Yeah. Everything up till that point had been relatively easy. I was a good student. I applied myself, but I didn't over apply myself. Sure. Had a lot of other things going on, hobbies and interests as one does, and it wasn't until really taking the MCAT for the first time that I said, "Oh, this is This is something different. This is different. This is different. Yes. I rolled into my first MCAT. I'd been on a fishing trip for a week and a half with my dad in South Florida, and came back the next day. I took the MCAT, and while I'd studied, I did not study appropriately.
Yes.
And so I realized, all right, this is a different league than what we've been playing in, and takes a different level of commitment. And I think that kind of kickstarted it off. And medical school, I kind of treated it the same way. I made sure I had some fun in medical school. Sure. Got to for psychological purposes.
Yeah, indeed.
I think that's really important for medical students that are going through or just starting out. Like you've got to make sure you take care of your mental aspect because you'll just burn out too quickly.
Yeah. Read a book occasionally.
100%.
Go outside. Yeah.
100%. But no, it's the most challenging thing I've ever done is go to medical school.
No, and all of a sudden you're around a lot of smarter people very quickly. Yeah. That the things that you didn't have to worry about, all of a sudden you do have to worry about, especially because there's a subtle level of competition that's going on at all times 100%. There that you have to kind of dig into a little bit. And you may say, well, geez, I don't really want to. Okay, well, too bad you're doing it anyway.
You're forced to.
You're forced to.
You're competing for spots. You're competing for residency spots and training sites and locations and experience. Everything is a competition at that point.
It is. Now, we typically, most of the guests on this podcast so far, we have made a decision between whether or not we're going to, after our clinical years, the third and fourth years, whether or not we're going to go internal medicine or surgery. Those are usually the dichotomous cut point. Mm-hmm. You chose something a little different.
I did. I went into pathology. I think my initial interest in pathology, whether I knew it or not, was in undergrad at Florida State. I took a basic histology course. And
why on earth would you take a histology course in undergrad?
I'm not even sure.
There are other courses there.
I'm not even sure I knew what it was at the time.
I don't know what it is now, as a matter of fact. But
and so it was fascinating to me to see things at a cellular level and kind of understand them, and I was really good at it. Yeah. I was really good at it. I was looking at a microscope, and it was natural. I was really good at it. I remember my last day in that course, and I was turning in my final, and my professor knew was interested in medical school, and he said, you might want to think about going into pathology. And I didn't really say a whole lot because I didn't even know what pathology was.
I was like the guys that solve crimes? Is that what it is?
And I was like, oh, okay, great, thanks. And that was it. It was as I was turning in my final, and that was the last time I'd spoken to him. And so I left from there, and that was just put that away and never even thought about it again. And then third and fourth year came around. I was going through my core rotations. A lot of stuff I figured out I liked, I didn't like. I thought that I was going to be doing, I thought I would end up in ER, internal medicine, something like that. I feel like I've got the personality for that kind of thing. I like patient care, I like patient contact. And then I had my general surgery rotation. It kicked my butt. It's long hours, very extremely demanding.
Some of the most difficult work you will have ever done to that point.
100%. I was getting up at 3, 4 in the morning and getting there and rounding up. I mean, it was extensive.
Yes.
And I remember I talked to another resident at the time, or another medical student at the time at the same core site. they said, you might want to think about taking a pathology elective after this. Those guys, have a lot lighter day. They eat breakfast and lunch every day in the physician lounge for an hour. It's great. They look happy. And I said, yeah, that sounds lovely.
This is a good idea.
Let's sign me up. So that's what I did. And boy, within about a week and a half, I was hooked. I loved the work. Loved learning about different things underneath the microscope. And although I miss the patient interaction to an extent, I still get a lot of physician interaction throughout my day. And an interesting thing that I'll tell you, I remember later on in my fourth year, I can't remember, I was doing urology or something like that, rotation. At that point, I kind of already made up my mind. It was late fourth year. I was going to do pathology. And my attending physician knew that. And I remember he put on my evaluation at the end of the month. He said, "Waste of a personality on pathology." And I didn't know how to feel. I was like, "Thank you." Is that?
I'm going to try and put that a little bit more diplomatically and say that most of the pathologists that we had from my medical school class, of which there were two, they were pretty introspective, not very outgoing or garish folks. Incredibly intelligent across the board, no doubt about that. But it seemed like the clarion call of pathology was, you're going to sit in a dark room and you're going to be quiet.
Yes, and I think that leads a good number of pathologists into that field.
There's a reason.
It's entirely accurate. I think people who maybe struggle with face-to-face interaction with folks, it's a good place for them to get into. People who maybe English is their second language, that is a good field for them to go into where they're not as comfortable, and things of that nature. So yeah, there are a lot of those.
And it may catch, and sometimes this gets a negative connotation, but it's really not meant to be. It's meant to be more descriptive. Some of the more spectrum disorders of our physician colleagues,
absolutely,
they tend to thrive in these kind of environments where you can just really hone in and be focused on this thing, and they're quite excellent at it.
Yep, and that's something interesting that's different, I think, about the group that I'm in now. Is there's 8-9 of us in this group, and I couldn't pick. And I'm just saying this, like, I couldn't pick more normal, as you can get for pathology, more normal individuals that can hold a conversation with someone.
Yes.
Trying to find that many people and get them in the same group for pathology is unheard of, and I think that's what makes our group very good. Is that we can communicate with our clinicians, on the phone, in person, and that serves us well.
Well, this is one of the things that I really wanted to talk to you about, and kind of let loose to the lay public here that's going to be listening, which is that pathologists are physicians.
Correct.
They are some of the best friends of physicians because they're going to get you the answers. Meanwhile, you are patient-facing and you are procedure-facing. They're going to let you know what you messed up, what you didn't get. My wife has a saying from breast cancer, biopsy, breast radiology perspective, which is you never want the biopsy specimen to say normal endothelium. Those are not good things. Okay. By the way, that means you biopsied a blood vessel. So you don't want to do that. So anyway, it's just goes to show you that I don't think patients think about their pathologist, and it's a crucially important field that we would not have the edifice of medicine that we have nowadays, would not be here as you know it if we didn't have our colleagues that were deciding pathologies.
100%. They never see us. All of our work is behind the scenes. A lot of us like it that way and prefer it that way. That's why we got into the specialty. We're just a name at the bottom of a report, although it's probably one of the most important reports they'll get in their entire life. And life-changing for them. But we're just that name. We never see them face to face. You still always try to keep that in mind, that even though we're not seeing those patients, that there's a real patient on the other end of that glass slide that you're reading at that particular time in the other end of that case report. Yeah,
and as of right now, vice versa, you will say that there is always a human physician's eyes that are looking at your slides.
100%.
Any biopsy that you ever get, any organ that has been removed, any sort of blood smear that is being evaluated, there's a pathologist and a professional doctor that is trained that is looking at these.
Look at that.
That has seen many thousands of slides.
Absolutely. And that's people ask me, what is a pathologist? What do we do? And the way I put it to friends and people who aren't in medicine is I say anything that they take out of the body during surgery or biopsy or anything gets sent to us. We look at it under the microscope, tell them what it is. Did they get it all, or did they leave some behind? And basically anything that you send down to the lab, blood, urine, spinal fluid, everything, we're responsible for all of that happens in the lab.
Yes.
Blood testing, CBCs, all of that falls underneath our umbrella.
Yeah, and so to say that you are helpful here gives it short shrift. It is essential. It is not just, man, you help make medicine better. It's medicine doesn't exist without you guys doing this kind of thing.
Yeah, we're solving the ultimate mystery. I mean, I get to say that I've looked cancer in the face every single day, and put a name to it. We don't know what anything is until it comes down to the lab. We have ideas based on imaging and laboratory testing and things like that.
Clinical suspicion on growth patterns, et cetera. Yeah, but you don't know until,
But until we actually lay eyes on it, we don't have a solid diagnosis. And that really, the whole treatment plan and everything else is waiting on our diagnosis to happen.
Yeah, from the medicine and surgical side, I know that we had a saying which was tissue is the issue. You got to get a slide down to the pathologist who's going to tell you what's going on here.
Yes.
Ultimately, they can always decide what the pathology was of a patient. So you go into residency. Now, let me take one step back. And we had mentioned a word earlier that you had taken a course in called histology. Maybe you can describe exactly what histology is for those even medical professionals that don't know exactly what that is.
Sure. Well, let's just talk about how tissue gets from the OR onto my stage, which is a part of the microscope that we lay the slide on to look at. So it's a little bit of an extensive process. I mean, it gets taken out. Say you do a biopsy in surgery or whatnot. It comes down to us. We have either a pathologist or a pathologist assistant there that describes it. If it's a breast that comes down, we're measuring it, weighing it, a lot of times imaging it there in the pathology lab to find out where that tumor is so we know where to look and take our sections from. We're cutting it up. We're selecting little pieces of that tissue that we want to look at underneath the microscope. If it's a biopsy, we're obviously going to look at the whole thing. Yes. A mastectomy, we're going to focus in kind of on that area of tumor. And we're taking those sections, putting into these little plastic containers called cassettes. They'll get processed overnight generally. It's a dehydration process. And then the next morning, that tissue will get embedded in wax, basically just a wax block with that tissue in it. And we'll put it in a microtome and cut it into very, very thin sections, a couple microns thick. Put that on a slide, and then it goes on a stainer. It stains with hematoxylin and eosin. It's the majority of our stains that we use most commonly, and it'll come out to me the next morning, and I'll take a look at it and make my assessment from there. And histology is me looking at it under the microscope on low or high power. It could be anywhere from 2x to 100x in certain situations, and we're looking at the cells, in their normal state in that particular organ or tissue, and finding out. Basically, we're playing the first game we play is benign or malignant. I heard you mention a couple podcasts ago, someone that's emergently sick, or someone you had to keep an eye on versus something that's not emergent.
Sick or not sick, yes.
And that's kind of what we play as well, benign or malignant. And we kind of start there, and then we tease it on down until we get to our final diagnosis.
Yeah. So we use individual stains that are going to bring out certain characteristics of whether it be cell walls or some sort of identifying markers of the cell types that we're going to see there. There's some basic stains that we have. You have some more advanced stains.
Yes.
We can get into fancy terms, Congo red and all this different stuff that you can bring out that bring out pathognomonic features of the pathologic slide that you're seeing there. So you can tell me if this is going to be a squamous cell carcinoma versus a basal cell carcinoma. And you certainly have your suspicion that looking at the gross specimen, I'm certain of that. Certainly the dermatologist or whatever physician that is excising this is going to have some clinical suspicion. But you ultimately are going to get that call because I would bet that you've been fooled before.
Absolutely. Tumors are known for, losing, I guess, some of their defining characteristics, particularly as they metastasize or become more poorly differentiated, which is typically more aggressive. And so it's hard to tell sometimes where a particular tumor came from. If we've got multiple liver nodules and we suspect metastasis, we don't have a primary site. That's up to us as a pathologist to try to figure out.
Yes.
Imaging helps a lot, but you can't image the whole patient right up front. One, you can't necessarily always get
That's true.
insurance to pay for it.
That's true.
And so that kind of leaves it up to us with a tissue biopsy. And as you stated, yes, special stains are incredibly helpful. A lot of times, just patient history. Just knowing if there's blood in the urine
of course.
all of those things. So sometimes when I'm stumped, I solve more cases just by picking up the phone and calling one of my clinicians and talking to them than I ever have with, fancy stains and other things like that.
Look, this is the thing that I say oftentimes. I've got an unfair advantage. I get to talk to the patient. Correct. I get to hear oh, you've been feeling poorly over the past 2 weeks, 2 years, 2 months, 24 hours. I mean, that changes everything right then and there. And so I get a clinical scenario. That helps me on my cheat sheet quite a bit to try and figure out.
I get a 2-word clinical history, altered
belly
neural status,
yes, exactly.
with, and they send me a liver biopsy. And
great, yeah, we'll figure this whole thing out. Yeah, but it does suggests something, which is that we're always doing Bayesian statistics in our brain. We're always including the clinical scenario, and it's changing our priors to kind of get honed down better on what is the higher probability of what's the underlying pathology. And if you can give probably a 2-sentence history to your pathologist, they're probably going to be able to hit this a lot harder.
100%. Man, anybody that's out there, the surgeons, radiologists that are filling out our requisition sheets for pathology, clinical history is extremely key. I've had a couple of clinicians in the past that didn't want to give clinical history because they didn't want to bias the pathologist.
Yes.
And that's just poor form and poor practice, okay?
Yes.
So I encourage you.
It's garbage in, garbage out. The more precise you ask the question.
I didn't want to say that, but you said it, so it's okay.
I will. It's hosting right
That is a term we use, yes.
Yes. But the more precise you ask your clinical question, the better answer that I can give you.
And I'll address that in my reports. If you put a question something that you want me to rule out, particularly on a case, and it's in my clinical history, I'm going to make sure that I address that in my diagnostic line and tell you that it's there or not there, or that I looked for it.
That's right. So now, let's go back just a second to the training, because now you've decided to do residency in pathology.
Yeah.
Not everybody in even the medical field knows what a pathology residency is like. So tell me about what this is.
So I'll give you a little bit of my experience. It's 4 years.
Okay.
There's no intern year, so it's not like some other specialties where you're kind of just, working as just an intern for a year, kind of get your feet wet and everything like that. No, you're cast straight into it. And it is completely different than medical school. Obviously, we're using some things that we learned in medical school, but we're not going into internal medicine. No, we're looking under a microscope, and medical students, particularly, up to this point, aren't getting a lot of training on pathology. At least unfortunately, I didn't get great training in pathology at my medical institution. And so it's almost like starting over again. And everything's new. You feel like you've got it. You're done with medical school, you're ready to go, and then it's kind of almost defeating. You're starting over again.
Yes.
And so that's challenging for a lot of folks. Is kind of doing that, starting over again. My first rotation was 3 months in autopsy. And autopsy was one of the most physically demanding rotations that we had for obvious reasons. And that's what a lot of people think that pathologists do all day. They think that we do autopsies, of course.
Yes.
I did my 60 or 70 in training. Our requirements were 50. And that's all I ever plan on doing. I don't plan on doing it anymore. As long as I can help it.
Yes, exactly.
Right?
I delivered 2 babies in medical school.
That's
the only 2 babies that I ever needed. I did it. I checked the box. Yeah, exactly.
And so I think autopsy was actually probably the perfect rotation for me to start out on, is because it gave me a good sense of what normal looks like.
Yes.
And that's the thing with pathology and really any specialty is
exactly right.
Getting your N of 100, a 10, whatever it is, however much you need, but knowing what normal looks like.
Yes.
That way when you see something abnormal, you may not know what it is.
You may, yes.
But it doesn't matter.
But your spidey senses say this is not normal. Yes,
correct.
That's right.
And it gave me a good sense of what normal was. I also got to see some really good cases of diseases running their course. We had a contract with the state of Alabama with the prison system. Any prisoners that were not homicides, suicides, they came to us. And so, as you know, medical care is not great in the prison system. And so we would get to see these disease courses just kind of run rampant till they're end.
Of course.
And
so full on tuberculosis.
Correct. 100%.
Tertiary syphilis.
Yes.
Really end stage stuff. Yes.
Yes.
That you read about in textbooks, but you don't see.
People never see, and I'm getting to see it, every day.
Yeah.
And so that was my first rotation, was autopsy. And then we're doing a number of other things. We're learning about the lab, so we're doing general chemistry, blood banking. We're going over and doing cytology, so we're looking at pleural fluids and CSFs, and
ascites,
absolutely. So and cytology is a whole different animal in itself. Most of what I look at is whole tissue slides where we're getting to see those cells in their setting, in whatever organ they came from. Cytology is different. Cytology is pulling those cells out of context, out of that tissue, and they're just kind of free floating, and you're determining whether or not they're malignant. You can't tell if they're invading into tissue because there's no tissue there. There's no stroma there. So you're looking at the nuclear characteristics, the cytoplasmic characteristics of those cells, and trying to determine, are these good cells, bad cells, and then what do I call them?
Yeah.
And so
on the pathologic side, on autopsy side, this is big picture. You're taking organs, you're looking at them, you're weighing them, you're seeing a lot of normals, because even if somebody's got a degenerative brain pathology, you can still have a normal liver with that. So you're getting a lot of your denominators growing large.
Yeah, we had our standard sections that we took on every single case, whether they had heart disease or not. We had our standard sections we were taking from the heart every single time.
You're going to look at the aorta. You're going to see if there's any sort of atherosclerosis.
Yep. And so we you get to learn a lot about what normal looks like.
Yeah, normal may not be so normal. I'm sure. The incidence of fatty liver disease has increased just as our metabolic health has decreased significantly. So normals may not necessarily be healthy. Yep. Those are just. So you're learning on the fly here in residency, as we all do. Yours is a little bit more intense under the mic. I mean, there's something about sitting for 9 hours and doing something where you're just looking under a microscope. And I mean, you have to train your eyes and your back and your other things that, like, whereas we were moving around and seeing patients and interacting and stuff, you're just dark room, silence, I guess. And
yeah, absolutely. Not as dark as a room as radiology. All right.
Yes, exactly.
But definitely a lot of sitting underneath the microscope. There's a funny picture out there of a first-year resident, and it's got their head, it's just a normal head, and it slowly morphs into the form of a microscope as they progress through training. And that's absolutely true. We're spending a lot of time under the scope, making a lot of very important decisions with every single slide that rolls across, your life-changing decisions for folks. And so you're mentally, you might maybe not be physically tired. Your back might hurt from bad posture or something at the scope all day, but mentally you're exhausted by the end of the day. My wife asks me sometimes, we'll pick kids up from soccer practice in the evenings. She's like, "Where do you want to grab something to eat tonight?" "Sure." "Where do you want to go?" "Well, I'm tired of making decisions. I made 80 decisions today." "Oh, man. And I am tired of making decisions, so I'm going to let you have this one, honey."
I will definitely say to my wife after days like that of, don't expect anything smart coming from me here. Right. Okay. I'm just here to exist for a little bit and space out. So,
but they, one thing I wanted to mention was, they did an interesting study one time. They followed, residents, they followed medical students, residents, and then senior pathologists' eye movement under the scope.
Oh yeah,
so multi-headed scope. They were tracking their eye movements, and the senior pathologist is putting the slide on the stage, and they're the ones driving, moving the images around, and they were following the medical students, eye movements, and they're jumping all over this, left, right, up, down, up, down. So kind of a similar pattern with the residents, but maybe not to that degree. And then you've got that senior pathologist whose eyes are just kind of locked in the middle of the field, and then as pathology scrolls across the screen, their eyes are automatically kind of drawn to it. And they followed their eye patterns, and then also how long it took them to pick up on that pathologic area. And of course, as you would expect, there was a greater distance in time depending on the amount or less training that you had. And so that was a very interesting study. And a lot of it is kind of what we do is pattern recognition. It's knowing what normal is, what you can let go and forget about and turn your brain off, and then picking up that one little area that's abnormal.
This is the exact same thing with EKGs, echoes. You put a normal EKG in front of me, my eyes almost gloss over. It's like I'm looking, but my brain isn't really. And then all of a
100%.
sudden, something will catch my eye as abnormal on an EKG, and immediately I go, wait a second, that's not supposed to be there. And my brain switches on for that kind of thing. Echoes, there's nothing in the world easier to read than a normal echo,
right.
Okay? But then something comes and catches your eye and you're immediately kind of jolted into position. So it's pattern recognition.
And that's what it is, pattern recognition. And they did a study, we had a joke in training, because it had just come out at that time. They did a study where they had pigeons reading, I believe it was breast or prostate or something like that. And they were flashing these images up in front of pigeons. And if they clicked a yes or a no box or a malignant or benign thing, they would get a reward, right? And what they come to find out was the pigeons were really good at it, but they were picking up on the patterns of this infiltrative tumor on these images. And, and we can delve into this later, but they eventually found that while they could distinguish the patterns on those images, which is a lot of what we do is pattern recognition, if you change those images out to something different or a little more obscure, they were missing those. So obviously we weren't losing our jobs to pigeons, but just to prove the fundamental basics, a lot of what we're doing is just pattern recognition as we're going through our cases throughout the day, picking up on that abnormal.
Now, and I really appreciate this, pathologists do have that physiologic background.
Yes.
They do. So you're seeing this through a lens of understanding, pathophysiology, not just looking at a slide and saying, oh, well, I see some sort of, multi-lobed neutrophil or something like that. You're kind of understanding the idea, I can make the connection between what that means and why the patient's short of breath.
Absolutely. We see the endoscopy report or something, they describe like a little nodular type, duodenal area or something like that. And I look at it and I see foveal or metaplasia or something on there. And I say, this is correlating with exactly what they're seeing. Like they did see something and
the story
it's
makes
nice.
sense.
Yes, exactly. And I get to kind of confirm that, and although that's completely benign, there's not really a whole lot to do, I would worry about, I'll put that in my report, and just to let them know, like, you saw something, then this is exactly what you saw. And I think it's also very important, and one of my mentors at UAB, where I did my training and residency, he was very good at telling me, what you needed to worry about. You see a lot of stuff that may not be normal, but it's not malignant, it's benign, it's some sort of metaplasia or whatever. And sure, you could spend $300 worth of special stains working this up and putting a name on it, but it's not gonna change the way that they manage the case. And I think he had a great influence just by telling me that and practicing that way on how I practice. And it's knowing how your surgeons, your clinicians are going to respond to what you call something, what they're going to do with that information and what they need to know.
That's right.
And that is extremely huge. And a lot of times it varies from clinician to clinician on what they're expecting and what they want to know. And so having a good relationship, with the clinician.
What are we going to do? Ultimately, where the rubber meets the road, is this going to help the patient at all if we 100%. Start to do a lot of these things? I had a mentor at fellowship who was talking to me about echoes and said, look, all of the academic bloviation that we have about this entire thing, there's 4 things you can't miss.
Right.
Don't ever miss those things, and the rest doesn't really matter. Yes, you can talk about it. Yes, you can be more accurate than somebody else with regards to that, but whether the E prime lateral is 0.6 meters per second or 0.7, this is not going to make a hill of beans here, okay?
Absolutely.
So don't lose any sleep over that kind of thing. So there's a lot of verisimilitude in the way that we're practicing, is that there's still a clinical element. There's still a patient behind 100%. This that is having some sort of presumed complaint. Now, there's screening, of course, that can come along too.
Right.
So you do 4 years of pathology residency at UAB.
Yes.
Did you consider doing fellowship after
I did.
that?
I did a fellowship in surgical pathology.
Okay.
At UAB.
At
Stayed
UAB.
there in Birmingham.
Okay.
Yep.
Yes.
Both of my kids
Excellent
were young. My second daughter was just born. She was less than a year old.
Okay.
My wife had her job there that she was absolutely loved, and I said, "This is a good institution."
It is.
The volumes here. The cases are here that you need to see. Like, there's no reason for
tertiary referral center is getting a lot of pathology. Yes,
and I think it was beneficial for me actually to stay there because my program director had a lot of trust. I built up a lot of trust with him as a resident. I guess I was a good resident. He trusts me a lot, and so I got a lot of responsibilities in fellowship. that I don't know that I would have gotten in other places, the trust. And so I was handling cases, like I was an attending physician. And obviously I had plenty of people I could go to if I was worried or whatnot, but I had my caseload. And so when I got out and I was practicing on my own, boy, when you hit that button the first time and there's nobody looking over your shoulder anymore, you're sweating bullets. And that helped, I think, transition and ease me into that a little better.
I was going to say, you're making the decisions then, and you're all of a sudden feeling the weight of, I need to really know what I'm doing. I'm going to scan this slide a couple more times.
Yeah, we don't get a second chance generally in pathology. If we send grandma home and say she's all clear, and then she comes back in 6 months and she's got metastatic melanoma to the brain, like that's on us.
Yes.
If we tell grandpa that he's got prostate cancer and he goes and gets a prostatectomy, and we cut that prostatectomy and we don't see anything, that's a big no-no on us. So we don't get second chances.
Yeah, coming out into practice, it fell some of the more simple things like, is this person cleared for surgery? All of a sudden, I felt a higher weight of like,
of course.
Well, geez, I don't know. Maybe we should just go and cath everybody. I mean, like there's all of a sudden, wait, how confident am I really in this? And that puts your feet to the fire for the first time 100%. That you're not quite ready for. Now, what are you doing in a surgical pathologic fellowship that you weren't doing? What was the additional training there besides a little bit more autonomy?
It was a heavier caseload. More time in general surgical pathology. Before, obviously, we were mixing in, autopsy and blood bank and different areas like that. This was focusing more on the bread and butter, things that are coming down from surgery, our breast, our GI, our ENT, and Whipple's, all of those kinds of things. So really focusing in on tissue diagnoses, and that's full year of that.
Let's also talk about that. Pathologists can be on call as well, and not just the forensic pathologist, but surgical pathologists are on call. And maybe you can talk about what exactly you're doing when you're on surgical pathology call.
Sure. Our call is a little different than other specialties. Typically, it's a little lighter. In training, obviously, bigger institution, you have more responsibilities, much more involved. Here in private practice, that's changed a little bit. A lot of times what we're on call for, we take weeks of call at a time in my group. There's 8 or 9 of us, so we're taking it once every 8 or 9 weeks. You almost forget that there's call until it rolls around next, of course.
Oh yeah.
But the majority of it for us is late cases in the OR that are running past 5 o'clock. You've got your guys there that have been covering that OR schedule all day, and they're tired, they're ready to go home, and there's some late cases, and you come in and relieve them. That's a good portion. The other portion is honestly tissue procurement, organ harvesting. Those cases typically happen in the middle of the night. What that is, they're wanting to transplant organs, and they're taking a little biopsy of those organs. Usually it's liver and kidneys, and they're sending them down to us, and we're making a down and dirty slide. It's an intraoperative consultation, also called a frozen section. And it's just a quick 20-minute, we can make a slide, look at it under a scope, and give them a good idea on if that organ is healthy enough to transplant into someone. And so those usually happen in the middle of the night because they're trying to fly those organs generally cross country or somewhere else. And you want that fresh OR team that's coming in first thing in the morning to transplant those organs. So those aren't fun. Those happen in the middle of the night. But
no, they aren't.
Those
but it's
calls,
necessary.
Those calls are not. They're not, every day. Some weeks you get lucky. You may not get a call. But we're not sleeping at the hospital like some other specialties or delivering twins in the middle of the night, back to back or anything like that. So there's a lot of aspects to pathology that's very nice as far as just having a family life and good quality of life and home time. And that's honestly a big part of what led me, into pathology as well.
Yeah, something
that can't be overlooked.
Medical students to think about.
100%. Last night, for instance, I got off work, I went home, cooked dinner. I played soccer in the front yard with my 2 girls for about an hour and a half till it got dark, and did some farm chores for my wife, and then, came in the house. But that's a normal afternoon for me. It wasn't.
It's almost like a normal human.
Right? It's nice.
Okay.
So, very blessed in that aspect.
Well, I do think you brought up some interesting things that I just like as a medical aside for the lay folks is that, most organ procurement is done in the middle of the night. That is virtually across the board. And again, it's for the transplant surgeons. It's different transplant team that takes the organs out than are to put the organs in, as they are going to be shipped out to various different places in a somewhat limited radius from the donor. And it's always 2, 3 in the morning. We get the emergent echoes from our side. We want to make sure that this heart is.
There's always a delay.
There's always a delay. Yes. There's always like that. And the heart, by the way, is always the last one to go because it has to perfuse the other organs as it's going. So it's anyhow. But those are important parts of our job. It's it's necessary to kind of be able to facilitate this organ donation and harvesting to help as many people as we can.
Absolutely.
So it's something that we take seriously and have a lot of reverence for. The other thing that I wanted to kind of harp on is that when you're doing on-call for surgery, you're also looking at margins. And maybe you could speak to, both the physicians and the lay audience about what that really implies.
Sure. So a lot of times during surgery, the surgeon's in there and maybe they can only get into that specific area one time. They're there, this is their shot. They need to know if they need to take this mass out, leave it, what it is. And so what they'll do is they'll send out a little tissue, fresh piece to us in the lab, and we'll make a quick slide out of it. And it's called a frozen section. We take that tissue and we basically, instead of embedding it in wax, we put it in a different substance that kind of, we freeze it at very low temperatures. It turns hard and it kind of acts as a block. We put it again on the microtome and cut it into very thin sections, and then we stain it right there. This whole process from the time the tissue hits our laboratory till we give them a diagnosis is about 20 minutes. And that's because patients generally under anesthesia and they're on the table.
So the surgeon is waiting there.
And he's waiting impatiently.
He or she is scalpel sharpened and is waiting right there for you to say whether or not
what this is.
Good or bad. What this is. Yes.
And so a lot of times, we'll call them back and say, hey, this is tumor, this is what it is. And then they'll go ahead and resect it. Other things that we do for those intraoperative consults is a lot of margins and things like that. Those can happen on breast cases sometimes where they want to make sure that they've gotten completely around the tumor. Sometimes breast cancers, are multifocal. Sometimes they have little fingers that kind of trail out from the center of the tumor, and we want to make sure we're not leaving any of that cancer behind. And so they'll send us margins and we freeze them, look at them and tell them, hey, you've got it all.
That's right.
So that's a big part, and it's a big deal because, you're on the hot seat, you're on the spot, you're guiding that surgeon's hands essentially.
Right. That's right.
And so we're leading them at that point. And
the surgeons are dependent upon you and your interpretation of this information.
100%.
Yes. Now there's also some element that you're taking a 3-dimensional structure and you're cutting this into 2-dimensional slides.
Yes.
So, I'm sure there's plenty of sayings about this from a pathologic perspective, but sometimes you could hide a house in these different dimensions that, there's got to be some margin of error of things that you're not getting the full information.
We call it tangential sectioning, where sometimes, it's not facing up or laying horizontal or anything like that. It's kind of sectioned tangential through maybe the skin surface or something like that, and it makes it very challenging to read. Levels are our friend. So when I mean by levels is we've got that block of tissue, they've taken their slice off of there for us to look at, and I say, hey, cut down deeper, take me some more, and see if we get through this.
Give me some dimension to give me context.
Or see if we hit anything else. And sometimes you can follow something through, it may not look like it's quite invasive, might look like it's in situ or something like that, but you're a little suspicious. You start getting levels and you can follow that one little area and say, oh yes, it turned into something invasive, Mm-hmm. So yes, you kind of section through it there.
Well, and certainly you feel badly for the patient in that sense, but you also feel better about yourself of saying, like, I'm giving you true, accurate information about where this is. Is this escape the capsular enclosure of this particular pathology?
Yeah. We always keep the patients in mind, but it's interesting because it's not uncommon for someone to walk in my office and say, hey, Scott, I've got a really cool case to show you. Cool for us as pathologists is completely different than for the patients,
Be very leery when a cardiologist says interesting, okay?
Right, exactly.
Something not good may be going on, yeah.
Exactly, and so, and we share cases quite frequently, because pathology it's an art, really. We're looking at these tissues underneath the slide, and they're stained. It's almost the way I describe it to people. It's like looking at a painting, like an abstract painting. I might see something one way, and I show it to you, and you see something different in this abstract painting. And so a lot of times I share cases with my colleagues and just make sure, I'm barking up the right tree. We're all on the same page here, particularly for, malignant diagnoses and things like that, getting a second opinion. And so the last thing you want to do is you assign out a case and it go to a bigger institution, maybe somewhere they're going to go get treated, and they've got a room full of 17 pathologists looking under a multi-headed scope with everybody in their own specialty, and they say, why didn't Dr. Taylor from Tallahassee get this? When we're the ones taking grenades every day in and day out. So it's always good to get a second or even a third opinion in some cases from one of your colleagues.
Yeah, and being humble about that, because we all get humbled.
100%.
The things that we know for sure. I'm sure you've thought for sure this is classic breast adenocarcinoma, and it comes out squamous cell, and you're like, I would never have thought this.
100%.
But it's going to change the management too.
100%. Yes, absolutely. And I'm our goal is to always get the right diagnosis. Even if it takes longer, our turnaround time isn't met for that particular case, doesn't matter. Even if we lose money on the case, we got to put in more blocks, we got to do a whole bunch of stains, we've lost money, doesn't matter. We want to make sure we get the right diagnosis. And if that includes sending it off to one of the experts and doing that, or sometimes a clinician will call me and say, hey, I don't want to disagree with your diagnosis, but it doesn't quite fit the clinical. Happy to send this off, Yeah, and please. Hey, if it comes back as something different, I'm happy. I want it right.
I will change my algorithm too, because I'll learn from that too.
Exactly.
Yeah, and I'm glad you brought up something, because I wanted to talk about it, which is that the subjectivity of pathology interpretation. I mean, there's some subjectivity in virtually everything that we're doing, some things that probably aren't going to matter. But so let's take maybe some hematologic slides. The different concentrations of pathologic cells, so cells that are growing abnormally, white blood cells that are growing abnormally. Is this 10 on the slide? Is this 100? Is this 1,000? I mean, you can count 7 individual cells.
Correct.
You're not counting 700.
No.
So
absolutely not.
You have to get a kind of gestalt for that.
Yes.
And so maybe you can talk a little bit more about
and that comes into where some of our subspecialty training does, comes into play for pathology. We've got 2 heme paths in our group, and so when I get one of those cases and I get the lymph node here with these cells in it, I'll bring it to them and say, hey, what do you think the percentage of these cells? What's his kappa lambda ratio here? Do you think, or whatnot?
yes,
and
exactly.
So because they see more than I do, and that's kind of their particular area of specialty.
That's right.
And so you kind of get a good benchmark. But it's interesting, and one of the interesting things is pathology is you're always kind of resetting and recalibrating yourself on what your thresholds are for things, and it changes. It can change. Some people, the joke is sometimes you ask me this tomorrow, and I might give you a little bit different answer.
That's right.
But it does have these ebbs and flows, and some of that is, your internal consultants, other people in your group that you bounce ideas off of. You kind of see, oh, well, maybe I'm, a little undercalling this particular thing, or I need to bump it up a grade. Or you get some feedback from consults that you send out to expert institutions, and they maybe you're overcalling something a little bit, and so you're always calibrating a little bit, and that's why it's kind of an art form. It really is.
Yeah, it is. And you may think, or at least the lay public might think, that you would always overcall. I mean, you always want to make sure, but that's not, because you might be handcuffing someone to chemotherapy, 6 cycles of it,
100%.
that they would never have clinically had anything done to it. So it's you really want to Goldilocks this. You really want to try and hit it right, not over, not under. I mean, if you see one 7-lobed neutrophil, are you gonna jump up and down and call that?
Right.
As opposed to if you see a slide full of it.
I used to have one clinician who would always tell me, all I need to get you is one cell. And I would say, no, I would really like more than one cell.
Preferably more than one if you could do that.
Yes. Diagnoses, if you could do that for me.
Yeah, and I think that there's probably an element of, there's a difference between board question pathology and actual where the rubber meets the road. Because there's probably the well, yes, you should aspirate every cyst and send it for cytology, when at the end of the day, that's got to be incredibly low yield whenever you do that, and you're going to say, random bits of fluid here. I can't really tell you anything about what's going on here.
Right. Yeah, absolutely. If we sent every specimen that we took out, we would just be overwhelmed. You know. And there's some. It's interesting. We talk about that. There's some places where a lot of what we do is they do tonsillectomies or something on these young children, and it's like, well, it's hypertrophic tonsils, there's really not a lot of yield from us looking at them under the scope unless they're suspicious for some sort of lymphoma or something like that, And so the yield is very low. And so I feel like there's some specimens that a lot of what we're doing is just confirming, yes, you took off a toe,
Yes, it is a toe, confirmed one toe.
And so
carry on.
there's a lot of that. And then there's some places that don't send a lot of the amputations anymore because it's, you've got these big bulky specimens you've got to keep for a certain period of time. You got to worry about freezing them and then, processing them and having the PAs and all the resources that we pour into those specimens for pretty low yield, And so, a lot of clinicians, have to make those judgments on what they want to send down to us and not.
You don't just want to be spinning wheels.
Correct.
You want to be helping patients and colleagues. I mean, you want the things that you're saying here to be helpful in some way, not just, yay, we got a toe. Now, do you have any stories just off the top of your head of things that were totally incidentally found? Somebody did a hemicolectomy for something totally benign, and you find
sure. I have one just yesterday. I had signed out. They did a sigmoidectomy on a patient a couple months ago.
Part of the colon that you've removed.
Yes, older gentleman, and he had ischemic colitis, clear cut. Didn't see any tumor, no funny business, anything like that. Straight ischemic colitis. Put an ostomy in and everything else. He had some dementia, some things like that. Family was taking care of him, and he kept spilling, the bag and everything else. And so they went ahead and did the ostomy takedown just to help make him a little bit easier, easier to manage. Yes. And so I'm looking at that ostomy site and some donuts that they had sent me. Okay. And, those are run-of-the-mill specimens for us. That's, 30 seconds, 45 seconds. Bread and butter type stuff. Mm-hmm. No clinical history of anything. Mm-hmm. I saw some atypical cells, very, very faint atypical cells on the serosal surface there. Ended up working them up as metastatic cancer of unknown origin. And used some of my special stains. I've two of them as a PSA, PSAP. They're known for marking prostate, and they were positive for both, and so metastatic prostatic adenocarcinoma.
He had metastatic.
And so I have to call up my clinician who thinks he just did a routine ostomy takedown and say, hey, this patient's got metastatic adenocarcinomas, prostatic origin, at least that's what it's staining like, I want to check him out. And so my clinicians hate seeing
the BSA is 70.
It's a weird feeling because I call my clinicians and they answer the phone and they're always nice to me, of course. But they know what's coming. They're like, which one now?
Yes.
Especially when it's unexpected. They understand. Yeah, okay, I took a biopsy of a colon mass and I sent it to them. Like they expect that call. Yeah. But when they don't necessarily have anything in the back of their mind, and here I am calling. They do not,
No, and so to kind of translate for that was, this bowel disease was not getting good blood flow. We call that ischemia. And so ischemic bowel, mostly anything ischemic is going to die. Yep. And it's going to die quickly and painfully and septically, and it's going to go down. So the surgeons removed that. They took that end where that section had been removed and moved that area to the abdominal wall so that they could defecate through that area. And then as they put that back into place, reconnected it, they found that there was actually cancer there that was of a metastatic origin.
And I pulled that old sigmoidectomy case. I pulled it, I reviewed it, make sure we didn't miss it. I didn't miss anything because
No,
it was
that-
my
that-
case.
yes.
I didn't miss anything. I brought it to one of my partners and said, hey, look at this. I just found cancer in this recent specimen. Make sure I didn't miss anything in this one. Had them look at it too, and confirmed that no, in fact, it was not not there.
And again, you're not doing you're not slicing the entire specimen. You're not taking every single part. You can't do that. So there is some margin of error there. And this had come up with some later questions that we'll cover of Jeremy Sunseri during his podcast about sentinel lymph node biopsies.
Yes.
And you're getting 4 or 5 micron thin, tissue thin slices. That's incredibly small. That's thousandth of a millimeter. But you can still miss some cells that could be there.
100%.
This is an imperfect science that we're going to get here.
100%. Sometimes I pick up on metastatic disease in these lymph nodes, and you might pick up 6 cells, and you're like, if that histotech would have turned the wheel and faced that block in a couple more turns, these 6 cells would have been gone. They would not have been here, and I wouldn't have been able to make this diagnosis. And why we try to sample everything really well, and we put in all of sentinel nodes and things like that. You physically can't look at everything.
Every
you can't
cell.
cut
You cannot
every
look at
single
every cell.
slice
Yes,
and look
that's
at everything. We would never get through our day's worth of work. And it's the same thing with our bigger cases. We really rely on our judgment as pathologists, our pathology assistant judgment on what sections to take, what's going to be pertinent. And it's important for them to know what we need to sign out the case margin-wise. Is there capsular invasion in this thyroid nodule? We rely on them heavily to lead us. So it's really a team effort from the time, obviously in the OR, but when that specimen hits the door, from the PA to the histotech to everybody, it's a team effort on trying to make sure we get that right diagnosis.
Yeah, and also, are you taking into account things like the genotype of the actual cancer now? Because there's some further advanced technology. There's certain tumor markers, genetic types that will suggest that these are metastatic when you're looking at the sentinel lymph node biopsies. That's
absolutely, yeah. So there's a lot of different testing that we can do on these tumors now, and yes, it can tell things like what is their risk to metastasize over the next 10 years, or is this cancer going to behave poorly, and things like that. So there's a lot of that different type of testing that we can do on these tumors, and that's part of something that we have to keep in mind when we are processing these specimens and working them up to get to a diagnosis. If we order too many stains or have that tech cut into that block too much and we lose that tissue, then we can no longer do that extra testing for treatment purposes. What drugs is this tumor going to respond to?
Great point.
So we're really a steward in trying to preserve tissue as well for that type of testing, so that patient can get the appropriate care that they need.
And who knows what's going to come out next month that's going to require
100%.
That's
and
a great point.
Something that I've started to see creep into certain aspects of pathology is tumors are starting to be classified more and more on their molecular characteristics. So used to, and what it's been forever, is we look at the histology of the tumor and we kind of grade it, we classify it, and
what does this look like?
Exactly.
Yeah.
And even before we had special stains that might be able to tell us where these tumor cells originated from and stuff like that, older pathologists had to just rely on histology. But now we're getting to the point where we can do molecular profiling for these tumors. And there are some instances, particularly in some of our hematopathology and neuropath, where these tumors are classified strictly on their molecular profiles. If they have a certain mutation, it doesn't matter what this tumor looks like, this is what you call it. Whether it looks completely low grade or not, this is what you call it. It's a WHO grade 4 tumor. And so,
which is going to dictate your treatment plan
100%.
Or the treating physician's plan,
100%.
Which kind of aggressive chemotherapy they're going to go for.
And it makes it challenging for some of us in practice settings like mine, where maybe we don't have access to some of those molecular diagnostic testing modalities, and so we have to, send it off to someone who does, at a bigger institution, Gainesville or somewhere like that. And so it's challenging for us. We can tell the clinician, hey, this is what it looks like histologically, but until we get this testing back, it could bump this up. And it can be called something different. And so that makes it a little challenging, and it makes us think of potentially if that's what we get to one day, where we're basically taking this tumor, lack of a better term, just grinding it up in a grinder, running it through a machine and saying, this is what its molecular profile is. This is what this is.
This is what it is. Right.
Hopefully it never comes to that, because it might put me out of a job. But I think we're a little ways away there. But
yeah, but I mean, the world gets some benefit if that's the case. This is why I say, if I'm put out of a job,
it's a good thing.
The world's getting healthier.
Yeah.
So that's good. But it also goes to show you that, like, I have the benefit of being able to look at things like an echo or a coronary angiogram, which shows me some physiology. I can get some physiologic look at this. You're getting purely anatomical data. It's hard for you to get an idea of how this is acting. I mean, you can kind of interpolate maybe what that is based on how it looks and if it's invading the capsule or something along those lines. I get to see it actually doing live. The genes maybe bridge that gap, because it's suggesting the only way it could behave metastatically is if it has these genetic changes.
Yeah, and it's funny that you mentioned that. One of the things that we use a lot of molecular testing on is for thyroid FNAs. So it's a cytology specimen. You're looking at cells, they're not in tissue, and you're saying these cells look abnormal, atypical, but you can't call it papillary thyroid carcinoma. It doesn't have all the characteristics or whatnot, so you call it atypical, and it'll get sent off for molecular testing, and it will say, hey, this has a 25% chance of being malignant or 75% chance of being malignant, and so the clinician can get that report back and talk to the patient and say, hey, do you want to have a lobectomy here, or what do you want to do here? Do you want to FNA it again in a couple of years, sit and watch? And so they can kind of have those types of discussions.
That's a bespoke patient experience there, where we're talking about not about thousands of patients, about you. What do you want to do here? And I think that really enhances it, because it takes us a little bit outside of the bell curve and starts to talk about, no, wherever you are in this, we're going to make this specific to you. Yeah, and I've long since said that about a human pharmacome project, where we can take medications and get them specific for you. That is really going to be a boon to medications whenever we can get there. So, well, look, I could go on and on about the pathologic sides of things, which is really interesting. But we're going to change things just a little bit here and ask you, what is the biggest issue you think that is facing your particular fields over the near future?
I think a couple of things that are kind of on our horizon. As probably I'm sure a lot of your prior guests have mentioned, AI, that's kind of the tip of everybody's tongue right now.
That's right.
And how it's going to play a role in our field. I think it's going to be a little challenging in our field, just because, like I said, it's an interpretive. We're interpreting paintings, so it's going to be really hard to train a machine to do that, or a program to do that. I had fun with ChatGPT when it came out. I took a picture of under my scope of a breast slide, some benign breast tissue, and sent it in and say, "What's this?" And it tells me, "Oh, that's some good looking prostate you have there." And I said, "Okay, I think I'm good for a little while.
I'm all right for right now.
Right? I think I'm good." And so. I think that it might have its role in certain areas. There's some things that I think can be done. Just for instance, one of the things we do for breast cancers is we give out ER and PR results. And so we have special stains, or nuclear stains, and we count nuclei and say, okay, that's 80% of these cells are positive for estrogen receptors, and they know the patient can get treated or whatnot. And so there's AI can sit there and kind of analyze that slide and say, okay, I've counted up all the nuclei, and this is how many of them have this degree of dark staining, and can give you a number. And that might help speed up your day as a pathologist and things like that. Obviously, you've got to go back and confirm those things. We don't necessarily use that in practice currently, but that's something that I've seen out there.
It's coming on the horizon.
Could be done.
There's no doubt. Yes,
absolutely. Another thing is just really that I think is even closer in the pipeline for us as pathologists is just digitizing slides. Whole slide imaging. So just taking those slides, much like with a radiology film, we're kind of still we've got the physical film, we've got the glass slide. And glass slides are super cheap to make. They'll probably never go away.
But you do have to store them.
We do have to store them.
That's a physical storage issue.
Yes, that's a whole thing in and of itself. But digitizing those slides and putting them on the computer, and then of course, you're trying to store all of that data, high definition data, into the cloud somewhere. So a whole nother file storage system there. But I think that's actually closer on the horizon for us than some of the AI getting into our field.
Yeah, there is some element of the short-term solutions where AI can help, maybe with dictations and other things like that. That can, you can just say what's going on and not have to press it. That can help with our time. I think that's an aspect. Counting number of cells, I think there's probably some aspect of it being able to do that relatively soon. Will it be able to do the different stains and interpretation of that?
There's a lot of nuance to that stuff, and I just don't see how it's going to make it there. I'm very skeptical.
Okay, yeah, well.
Bread and butter cases, maybe. All right, if it's a tubular adenoma of the colon, maybe.
Yeah.
But boy, we're worth our weight in gold on that. 5 to 10% of cases that are challenging.
That's the old 95% of the training is for 5% of the cases. Yeah, so
that's it.
So that kind of leans into the next question, which I had asked about the near future. What about the far future? What do you think that really holds for pathology?
We're not a rapidly developing field as far as what we do. I think the molecular testing is going to advance us quite significantly with classifying these tumors, as I spoke to before.
Sure.
I think that's really going to change a lot with how we classify things. I think that's really the direction we're going, is the molecular testing.
Yeah. I think the molecular testing doesn't really lie, and it's with all the cells that are the metastatic cells are going to have to be able to have this information imbued in them, and so being able to test for that, I think, is really going to be a lot.
And there's a lot to it that we don't know what it means when we get some abnormal results back on that stuff, and we're still kind of figuring some of that out. And as we're figuring it out, we're applying it to these different subtypes of tumors and things like that.
Yes.
And so I think that's kind of where we're working towards right now.
Yeah. Now, in your mind's eye, how do you think of cancer? Do you think of cancer as some series of different diseases? Is it really one main physiologic process that
there's a
sparks off?
No, there's a whole lot of different things that factor into it. Lifestyle, genetics, diet. There's a million factors, I think, that go into it, and that's what makes everybody unique. Everybody's different.
I think so.
We get some patients and you look at their history, their pathology history, and it's 3 pages long, and you're like, okay, this patient's a grower. They're going to grow stuff.
Exactly.
Like, this is what
That's
they do.
Hobby.
They're good
their
at.
hobby is yes, exactly.
And then others, you're like, well, wow, this one's 92, and this is the first time we've seen this patient, and so it's.
Well, it also kind of that gives a kind of statistical prognostic value. It tends to be, if you've got a 30-year-old that's got a breast cancer, that tends to be an aggressive cancer.
Correct.
It's coming out hot.
Yes.
If you have a 95-year-old with a breast cancer, it's relatively slow growing. Of course, if they're not feeble and they're active, you would talk about treating that potentially. Right. But there is some idea of how likely these things are to kill you that you can kind of have a feel for just from a clinical scenario alone.
Absolutely, absolutely. And we can look at the cells too, and say, hey, these are very aggressive looking cells,
angry looking
high
cells,
mitotic rates, or their lymphovascular invasion. They're not behaving well. And so we can allude to some of that as well.
Yeah, and you had said this earlier. There's occasionally you get to, this is metastatic disease from unknown origin.
Correct.
It's so undifferentiated. It's such a pluripotential cell there. It doesn't look like anything. It doesn't look like prostate cells. It doesn't look like colon cells.
So a lot of tumors, they try to recapitulate like where they came from.
They're trying to behave like colon cells in the liver.
Exactly. And so a lot of times they keep a lot of those cell characteristics. Colon cancer, like you just said, they're known for being tall, dark, and dirty. They're columnar cells. The nuclei are very dark, and they have necrosis with them. And so you see that in the liver, and you think, okay, that's probably going to be colon. Yeah. But a lot of times it can be very poorly differentiated, and that's where some of our markers come into play. CK7, CK20, CDX2. These are all special stains that we can use to help differentiate where these tumor cells originated from. But there are, like you say, certain times where they're just so poorly differentiated, they've lost all of those markers. And that's a tough phone call to have, because you've kind of exhausted and did everything you feel like you can do as a pathologist. And you have to call up that clinician and say, you got me great tissue. I still can't quite tell you where to look. Or sometimes I have it down to, hey, you need to look at, GYN, lung, and maybe like upper GI tract or something. These are some places to look, and you can kind of narrow it down for them. But that's a disheartening conversation to have as a pathologist. Of I can't exactly tell you what this is.
The body biology doesn't have to play by our rules.
No, and the cancers don't always play well. The ones that read the book are great. The ones that don't are.
It's not really concerned about you getting the diagnosis right. It's concerned about growing,
doing its own thing.
Yeah, and it does.
Yeah, and one thing just for the listeners, I get asked this all the time. People want to know I get asked all the time. What color is cancer?
Okay.
And I always ask, well, what color do you think it is? And I always say, oh, it's black or it's red or some sort of evil, some color that's associated
sinister.
with evil, right?
Yes.
And while melanomas, can be black, and there are, some vascular tumors that are red and things like that, it's whitish tan, And so I thought for the listeners, I might want to share that little nugget, some of the...
Well, look, that was next year because I was going to ask for a fun fact about you, or your organ here. So that counts right there. So cancer is just as banally colored as general tissue is. Yep. So now, if you could talk to pathologists that are just starting off in their career, what advice would you give them?
Learn what normal is. Normal's going to save you. I mentioned it before, and it just can't be overstated. Learn what normal is, and trust your gut. If there's any inkling that something might not be right, something's a little fishy, you're not 1,000% sure in your diagnosis, reach out for help. Doesn't matter if you're first day on the job or if you've been doing it for 25 years. You'll be surprised. Sometimes I give a differential for a case that was shown to me, and I think maybe I'm throwing something out there that's in the dark, and that might end up being what it is, but somebody just didn't think of that in their differential or whatnot. And so,
This is kind of akin to what we were talking about of, your eyes going to the right place, your eyes going to the pathology whenever you get some training and some intuition. Your intuition can guide you in a lot of ways. If something just feels weird,
pump the brakes.
Yeah, do something there. Okay, trust that. That is a good feeling. Your body is trying to take care of you there. So trust that. I like that idea. Well, now tell me what you do for fun.
Oh man, so I'm a big outdoorsman.
Okay.
I like hunting, fishing.
Okay.
I just put in for my gator tags yesterday.
Yes.
For them.
Okay. Your typical pathologist life
bow
here.
Fishing,
Yes.
all that kind of stuff. No, I had a friend one time. He's like, you're the nerdiest redneck I've ever seen. And I was like, great.
Thanks,
But
I guess.
I look through a microscope all day, and then I go and do all that kind of stuff, when I'm off. Like spending time with my wife and kids. My kids are big into soccer. I was too when I was younger.
Yeah.
And great. So, we do a lot of playing soccer in the yard and traveling around to tournaments and things of that nature.
That's awesome.
So,
that's awesome.
A lot of fun doing that.
So you get to at work be looking down, hone down over a microscope, and then go be active when you get home. So that's
100%.
Great.
And then my wife, we've got a it's a hobby farm, but it's quite a bit. Goats, chickens, pigs.
You and I have different hobbies. I just want to be clear about that, okay? Because that's
you don't have this
work.
at your house?
No, not yet.
No, you don't have bees in your front yard?
Oh,
or
no,
beehives?
you're going to the bees level too.
No?
Okay, yeah.
So there's always something to be done at my house. I spend a ton of time outside when I get home from work.
Yeah. Does it feel arduous to you, or do you love it?
Love it.
Yeah. So it's just
absolutely.
Yeah. It's
there's very minimal TV or anything else that's watched at my house. We're always outside doing something.
Yeah. Now, how old are your kids?
7 and 11.
7 and 11.
Both girls.
Awesome.
And super sharp. It's funny watching them. Their attitudes that they have kind of blends over into their soccer play styles and stuff. That's kind of fun to watch.
Yes.
My oldest daughter's very mature for her age and very cerebral and things like that. And that plays into how she plays on the soccer field. My youngest daughter's a real go-getter, kind of a wild card, and you see it on the soccer field. She sticks her nose in the fan, and then she'll do it again just to make sure she didn't like it the first time.
Exactly.
And it's so fun kind of watching their little personalities play out in other areas of their life.
I had the exact same experience with my 9 and 7-year-old that we were playing soccer outside, and the 9-year-old is more pensive and thoughtful about it. And the 7-year-old, I was dribbling around her, and she absolutely just kicked me in the shins.
Yeah,
it was just like, just take it. And I was like, that's not fair at all. She didn't care about the rules.
Sounds like ours were one and the same.
Yeah, exactly.
Absolutely.
You shouldn't be slide tackling, but here we we are. So now, we often have scripts that we go through whenever we're talking, because we're often patient forward over in our specialty. So for example, the scripts that I'm going to talk about, if you're going to have a heart catheterization, it's these topics that I start talking about where it's almost like my brain just goes off into it, and it's 3.5 minutes long, and I hit the same cadence and do that kind of thing. I wonder, in your world, since you're not necessarily patient facing, do you have scripts where you start, when you're talking to surgeons, do you have this kind of, well, we can't always be 100% sure? Like, are there those things that you talk about?
There's certain things, to a degree. There are comments in our reports a lot of times. I get a metastatic squamous cell carcinoma, and a metastatic squamous cell carcinoma from the esophagus, the skin, lung, anus, anywhere. It's gonna look like a squamous. It's going to look like a squamous cell.
Exactly.
And so I've got my standard, comment that I put in there that says, "Hey, it's a squamous cell. They're going to look the same. They're going to stain the same from all these different sites."
Yes.
You have to look around.
That's more up to you. Yes.
It goes in our comments. But I can try to turn my brain off during those moments, and it comes out. And if you look at my reports for that particular comment or other similar ones, like, it's probably going to be same word for word, and it's not one that I just copy and paste in there. It's just instilled in my brain for those certain situations.
Yeah, this is like occasionally I'll have patients that say, like, you told me to check my blood pressure twice a day and something, and I was like, I would never do that ever in history. I totally really, I know for a fact, without remembering this interaction, I know for a fact I would never say that.
From me.
Yeah, my wife would get a CT in my head if I said something like that. So that's not what's happening here. So, all right. Well, look, we appreciate you being here. You ready for some rapid fire questions?
Yeah, I got one for you at the very end. Can we do that?
Good. Yeah, we can do it that way.
I'll go. And you can include it in the next couple podcasts if you like it. You can incorporate it in.
Okay. All right. So you have seen the podcast before, so maybe you'll be hip to this. Who's the smartest person in history?
So I feel like the low-hanging fruit here is Einstein or Newton.
Yes, which are not wrong, but...
No, but I think I'm going to have to go a little off the cuff here. Willis Carrier.
Oh.
An American engineer. He developed the modern air conditioner. And I believe it was 1903, 1906, something like that. Don't quote me on it.
Brilliant.
But just think about where we would be without, even in here, without modern air conditioning. Or ORs, what would that look like?
Well,
what would my laboratory look like? With all those machines with, that we wouldn't be able to run them. So talk about changing things quite significantly.
Yeah.
And what about in August in Florida, in Panama City, without
it would be unlivable.
AC, right?
Yeah, I know. I would lose my mind. Yeah. I know for a fact. So, kind of interesting and apropos to Einstein is he apparently created a refrigerator that had no moving parts.
Yeah.
Yeah. Now, as rumor has it, GE bought out the patent and would never sell it because it doesn't have any moving parts. And so, I mean, how does one come up with these kind of things? But this is just great technology that allows us to be alive now. So good answer on the AC there, okay? If we can live to be 1,000 years old, should we do it?
The correct answer here has got to be yes. But I'd want to see what the gross description was for that Model T 1000 human. Do we look like the 1983 Honda Civic with the hatchback that's a different color than the hood and then the door, where we've replaced all of these parts? And what happens when your mind is eventually going to go? What happens when we replace that? What's the quality of life look like, And that's not even thinking about what the effect of humans living to 1,000 has on the population, the earth, the resources. Right. But I figured if we're able to live to 1,000, we figured the rest of that stuff out already.
So, I would hope so. And I would hope that this would, include us being active. Not just alive, but alive and doing stuff and
having some meaning, still some passion in life. Right?
Yeah. I think that meaning is probably the thing. I found that to be the kind of defining purpose that I utilize for my patients, which is that our job is to get you to where you feel great so that you can add more meaning to your life. Absolutely. This is ultimately what we're here to do. And meaning doesn't necessarily mean living longer, by the way.
Right.
It just means the things that you're doing that mean something to you.
Yep.
Not to me, to you.
Having some joy and some happiness, yes, absolutely.
Increasing joy span. Okay?
Yeah, there we go.
Now, do you want it too cold or too hot at night?
Oh, absolutely. Too cold.
It's too cold.
You can always put more on. You can't take more off.
I can't say it enough. Yes.
Yes, too cold.
Yes.
Easy answer.
Hard agree. What is one thing you would tell yourself if you could go right back to when you started med school?
Probably a couple different things. One, go ahead and marry my wife then. Don't wait any longer.
Yeah, just go ahead.
Two, imposter syndrome's real.
Yes.
And I think I didn't necessarily even know I had it until I started kind of reflecting on things. I always kept waiting for them. I was just sitting there. Somebody's going to pull me aside one day and be like, "Hey,
they're going to find me
hey,
out.
guy,
Well,
you shouldn't be here. You don't.
We messed
belong."
up. How did you get this? Yes.
And so, and obviously that never happened. But you're surrounded by what they say is the top 1% of the population. As far as intellectual abilities and things like that, and you start thinking to yourself, I don't belong with these guys. These guys are super smart, and you don't realize that you're performing. I mean, you're performing the whole time throughout that, but you always feel like, man, I just don't belong here. Same thing. I come out and I'm starting pathology, and I've got these pathologists that I'm working with, has been doing it for 25 years, can do it with their eyes closed, stand on their head, and it's like, I'm not that yet.
Our decision means the same thing,
right?
Like we get paid the same amount for that. Yeah.
Do I belong here?
Yeah.
And ultimately, you realize it quickly that you do, but it's always kind of there in the back of your mind. So that would be you just kind of have to try to get past that. Yeah. And then to take every opportunity. My last thing would be to take every opportunity that they give you during training. If you're on one of your rotations, you're doing ER, and they say, "Hey, would you like to try to run this code when it comes through the door?" They're not going to force you to do it, but you could certainly say no. But you trust in your training.
Now's the time.
And try it, because you might like it. And I was pretty good about that and cognizant of that. I think I wish I would have been a little more aggressive, actually seeking those opportunities instead of waiting for be asked or whatnot.
Yes.
And so even the stuff I maybe known I wasn't interested in, just to get that experience. Because when I did do those things, I was like, wow, I perform better than I thought I would. My training has kicked in, and I do know what I'm doing a little bit, And so I wish I would have taken a little bit more of those opportunities, because at that point in training, you're somebody else's baby. Like, they're not going to let you fall. They're not going to let you hurt the patient.
Not going to let you get dangerous.
Right. Yes. That's why you've been entrusted to them. Mm-hmm. But that's the time to learn and make those mistakes and go through that process. And so, I would encourage all the medical students to kind of put themselves out there.
That's the really great answers, really sage advice. I do want to hone down in on the imposter syndrome just for a little bit, because that is really something that's sage that you said there. It's true. It happens. You belong. Like you can do this. Yep. I certainly was concerned at every step along the way for the exact same things that you had said there. And then eventually you realize, no, it's... Now, maybe we all don't belong. Now, that's one thing that could be there. But either way, you just keep digging in and keep trying harder and be humble about yourself. And then you're going to continue to learn a lot more than you ever thought you could do. So great answers. All right. What is one current medical treatment or therapy that we are going to shudder at in 15 years that we used?
I think some things are going to change. Got to talk about some things that are going to change a little bit.
Take your time. Yeah,
I think birth certificates are going to be different.
Okay.
I think you're going to get your birth certificate, but I think you're going to get something, thumb drive, whatever it is, where you're going to get we're going to do some whole genome sequencing.
This is your DNA.
Yeah. And you're going to get that, and that you're going to have that, from birth. Now, obviously, there's going to be de novo mutations and things like that kind of along the way.
Sure.
That can change things. But, I mean,
that might actually be formative, too. If all of a sudden you see these changes have happened over here and that this predisposed you towards some sort of condition, well, then you know that happened spontaneously as opposed to germline or
Correct.
something. So, yeah.
Yeah. But, let you know what disease processes you might be predisposed to. Mm-hmm. Do you metabolize certain drugs appropriately as well as others? Or are there certain antibiotics maybe you shouldn't take? All kinds of things.
This is the Human Pharmacome Project writ large. And then at some point, I think we get the epigenomic idea of we can utilize even intronic DNA, DNA that's not usually coded for protein, and we can utilize that and make brand new proteins that can do things. We can make red blood cells that have their hemoglobin that's better affinity for oxygen or something along those lines. I think that's a project that comes along too at some point. So, birth certificates. That's one I didn't expect here. This is a good bingo
Yeah,
card
thank you,
there.
thank you.
Okay, all right. How about what is the best song of all time?
Oh, I'm a country fan, so
Okay.
I'm going to say some Charlie Daniels. The Devil Went Down to Georgia.
All right, that's a great one. Yeah,
Right?
yeah,
That's a good one,
fantastic.
right?
I know. Everybody knows it. Everybody loves it.
Yeah,
I mean,
it's great.
so it's a crowd pleaser. Tell me what books you're reading.
So I don't do a lot of reading for pleasure at all.
Okay, all right.
Never have.
You're working on the farm, for
Yeah,
God's
exactly.
sake.
That's
Okay.
the majority of my evenings and where a lot of my free time goes. Never have been a big reader. Wasn't necessarily. I mean, obviously you've got to read for medical school, and
Oh, yeah.
I read my journals and things like that now to stay up to date on literature and current practices and all that. But as far as reading for fun, it's just not my thing. I'd rather be out there doing stuff, working with my hands, things like that. Interesting story about reading. First week of medical school, I come in and they teach us, they got a guy that comes in, and for the first week, we're learning about how to speed read. They think we need to do speed reading for medical school, right? And so you should have seen it, Don. There were people that were dropping out in that first week because they say, oh no, like I have to be able to speed read to get through medical school. This is crazy. There's no way I can handle this. So people were dropping out. And, I attempted it and was not very good at it.
Yeah, it's kind of a learned thing.
And they made some
good.
statements, you'll retain 60 and up to 70% of what you speed read and things like that. But my favorite part, and the guy ended up being the best man at my wedding, but I didn't know him at the time from Adam. And he sat next to me, and we're in this big auditorium. There's 140, 160 students in there. And we got these microphones. You push the button and your voice goes out over the whole auditorium. It's the last day, and the guy asked if anybody has any questions. And my buddy gets on there and he goes, hey, he says, what do we do when we get to a word we don't know? And of course, the guy said, well, you stop and look it up, look up the definition. And of course, my buddy got back on there and he says, I don't mean to be disrespectful, sir, but this is the first time I've ever been to medical school. And there's going to be a lot of words I don't know. And I immediately went, I like this guy.
This guy's all right.
Good.
This guy's all right, yes.
Me and him are going to get along just fine. And so, I remember that day. But no, speed reading did not stick with me.
No, it did not stick. It was not a talent that,
unfortunately.
I'm not sure. Yeah, there's a buddy of mine who can speed read, and he talks about it, and I'm like, no, it just doesn't land on me.
Right.
Well, do you listen to any other podcasts or anything else that you find time for whenever you can?
A few. My wife makes funny, but I do a little FSU sports
podcast.
All right.
Yeah, you're allowed.
A little sporting guy. But no, that's pretty much it. No, not a lot of podcasts. I do some music and stuff like that. But.
Gotcha. Well, we'll have to have you out to the soccer field on my soccer team. We're playing in the league here.
Are you?
Yes. So
you
we'll
play
talk
one
about
of the
that
adult
offline.
leagues in
Yes.
town? I used to do that when I was still going to school and stuff.
Yes.
I was doing that. So that's great.
I'm just waiting for the ACL to tear. This is really all I'm doing it for. Okay.
Yeah.
So. All right. Now
I've got one question for you.
Please. Mm-hmm.
I like asking other clinicians this. I think their responses tell a lot about them. But if you couldn't do medicine, you had to go back and do something else.
Yes.
What do you think you would have liked to have done, or what would you have ended up doing?
My dream going into college was to be an architect, but I had the math. I didn't have the art. I would love if somehow that could be, if I could design buildings or something along those lines, that would be great. My family was, it's kind of tongue in cheek, but they were kind of disappointed I wanted to go into medicine. They thought, you'd be a good engineer, okay? Yeah. So anyway, but either way, so I would think something about that. If I could find the artistry and doing architecture, I would be, the kid in me designing bridges or buildings would love
Interesting.
that. Yeah. But I just don't have the talent for it, so that's all.
Yeah. Love it. Good answer.
All right. No, hey, look, I love this idea. We may be incorporating this into our new
Feel
rapid
free.
fires.
Feel free.
Okay. So we'll give you some coinage for that. Okay. Scott Taylor, where can the folks here get in touch with you and your group?
Oh, sure. So KWB Pathology Associates, we're in Tallahassee. We've also got an office over here in Panama City. Mm-hmm. You can email me at staylor@kwbpathology.com. You can also call the office, ask to speak to me anytime, or just swing by. We'd love to give you a tour or anything like that. Really? We like visitors. As pathologists, we don't get a lot of visitors.
I know.
So we love it when we get visitors to
people
the lab.
Interaction. You don't hiss whenever the door opens or anything like that. Yeah. So, well, awesome. We'll have some connection information here in our show notes here. So thank you so much for being in our community. Thank you for doing the things and making physicians better at the job that we do and trying to take care of patients. Thanks for being so knowledgeable and personable, and thank you for helping us make medicine better together.
Appreciate it. Thank you.